Is it okay
So,
if I have my coffee?
absolutely, absolutely. Hello, and welcome to the Prolongevity podcast. I'm Graham Phillips, and welcome to the first episode with Professor Robert Lustig. Now, in our first episode, we'll be discussing Robert's background in medical school and what brought him to the conclusion that there is another way to live in good health for longer. Do join us weekly as we release a new episode for you to sit back and listen to, and do let us know what stuck with you in the comments below. I think you need very little introduction, and I'm not going to do one of these long intros because, to be honest, we'd have to spend an hour on the intro, which I guess isn't necessarily the most productive thing. So I'm just going to
Yeah, I'm
briefly.
not. I'm not interested in hearing about myself. That's not.
Exactly. So all I'm going to say is that you're a pediatric endocrinologist, and you're extremely highly respected in my world. And my world is the world of eat real food, let thy food buy thy medicine, and let thy medicine be thy food. And as is well known, you're the author of several different books. We're here to talk today particularly about Metabolical. But in addition to having written many books, you've written numerous scientific papers. And I think the point about you, Robert, is that everything you say is based in science, based in evidence, and based in clinical practice. And I think that's pretty unique in our world. So we are honored and delighted to have you with us.
Well, thank you, Graham. But to be honest with you, I don't know why that's so unique. That's what it's supposed to be about. And the funny part is the science works. And, I think people know that, or at least some people know that. But, we've learned a lot about social media lately.
But some people call it anti-social media.
Yeah, indeed. Well, I'm very anti-social media. Basically, I let the science do the talking.
Yeah. I think it's the way that you're able to articulate this complex science, which kind of is a lovely segue, actually, because I first came across you because of that incredible YouTube, uh,
Yeah.
Sugar the Bitter Truth.
Yeah, it's nuts.
And
It's now, 12 years old.
yeah,
I didn't think my mother would watch that, never mind 14 million people. I don't get it. I still don't get it.
I think you're underestimating. The last time I looked, it was 15 million.
No, I don't think, well, whatever.
But I just think, given the subject matter, which is a fairly abstruse 90-minute discourse on the metabolism of a very specific sugar,
Right.
what's the background to that video, and why do you think it's become the cult that it has? I came across it out of the blue, and I was spellbound for 90 minutes. I have no idea why, and I must have watched it half a dozen times.
Well, I have no idea why either, because that was about my worst presentation ever. Um, that was the first talk I'd ever given to a lay audience. Okay, I've given talks to scientific audiences for decades, but I was nervous as hell, and because I didn't know if everything I was going to say was going to be going right over their heads. I didn't know if what I had to say was going to be meaningful to them. I had never done it before. So UCSF, University of California, San Francisco, does these mini medical schools for the public, to try to bring the ivory tower science, down to, to the masses, in meaningful bite-sized ways, and, on different subjects. And this one was on nutrition. And so I was asked by the head of the CME department, if I would give a talk within that. He didn't tell me what to talk about, but I had realized, just 2 years, 3 years earlier than that, about, these very specific dangers of sugar. And up to that point, sugar had basically played sort of a non-contributory role to the concept of chronic disease. And I thought, well, this is what I need to talk about because this is a big problem. And so I put this thing together, not having any notion about the fact that it was even being taped or videoed. I thought I was just giving a talk to 200, lay people in the San Francisco area, and that was it, and it was over. Because if I had known that it was going to be videoed, I'd have worn a better tie. I wore that silver tie. My mother had just given it to me, and I thought it was ugly, but I thought I would at least honor her with
You made your mum
once.
made your mum proud, like a nice Jewish boy should. Yeah.
I guess so.
Yeah.
I guess. Anyway, and that's the story. And all of a sudden, people started watching this thing, and I don't get it. I still don't get it. Every time I look at it, I go like, why in the world would anybody want to like slog through this? But I don't know. They do. I think one of the reasons that video has done so well is because it actually demonstrates mechanism. When you tell people to do something, they don't do it. When you tell people why, they still don't do it. Okay. But when you actually demonstrate, well, here's what happens when you don't do it, then you finally have a chance for some compliance. And that's what we've been doing in our clinic for the last 20 years, is basically actually sort of taking people through the science and making it clear what the ramifications of your action or inaction are. And it makes a difference.
Yeah, I mean, I had no idea that was your first presentation. I assumed that was, this is your 100th, and you certainly didn't come across as less than absolutely proficient, confident. And my day job, as you probably know, is community pharmacy.
Yeah.
And we see ourselves at that interaction between the patient, the drug, the doctor, the prescriber. So we spend our lives, if we're doing our jobs properly, explaining complex science to people in a way that's meaningful. So, that way of being a professional makes complete sense to me in terms of my day job. Now, like me, you were conventionally trained. And like me, you drank the Kool-Aid, if we can put it that way, and practiced in a conventional way for a considerable amount of time. And then
I would say the first 20 years of my career, I basically did what I learned, and I did what I was told.
And guilty, I've written a mea culpa myself about that. What changed? Because something happened that made you not just divert by 10%, but it's a complete U-turn, isn't it, in the whole approach?
I wouldn't say complete U-turn. In Metabolical, I sort of go through sort of my genesis, if you will. I was prepared for this. Chance favors the prepared mind, Louis Pasteur. I majored in nutritional biochemistry at MIT in undergrad. And I learned very early on that, different foodstuffs were metabolized in different ways and generated different biochemical and metabolic responses. So I had learned that, very early on. Then I went to medical school, and they beat it out of me and told me everything that I had learned prior was of absolutely no use in terms of clinical care patients. And I was in medical school to learn clinical care patients. And so they basically told me to cast all of that aside. Whenever I would bring something up in class, I would get from the other medical students, like showing off or whatever. I'm not trying to ask a question, but Anyway, so I just sort of got my head handed to me over the course of 4 years. And, these were the gurus. This is how you practice clinical medicine, and, prescription pads and procedures. And that's what you learn in medical school. And that's what it's about.
Yeah.
And so that's what I did. And I did that for a lot of years. And then I realized my patients, of course, weren't getting better. And then I also, moved to St. Jude Children's Research Hospital in Memphis, Tennessee, in 1995. And I'd always had this idea about what might be driving obesity. And we had this cadre of very unfortunate survivors of brain tumors. So St. Jude's a cancer hospital. We had all these kids who basically survived their brain tumor, had surgery or radiation on their brain tumor, only to become massively obese. This is a form of obesity called hypothalamic obesity, because it's damage to the area of the brain that controls hormones, called the hypothalamus. And the hormone leptin had just been discovered, just the year before. Now, leptin is a hormone that tells your brain how much fat is on board. And it tells you whether or not you are energy sufficient or energy deficient. And so in that way, it basically either gets you to eat a lot or it stops you from eating.
Yeah.
And it also tells you whether you can burn rapidly or whether you have to conserve.
Yeah.
Okay. It's like a servo mechanism on your house, your thermostat on your house. All right. So when it goes too high, things shut off. Okay. When it goes too low, things turn back on again. And so this hormone leptin had just been discovered. And so I postulated, years ago that because of the tumor or the radiation or whatever, or the surgery, these kids couldn't see their leptin. Right. And I was in charge of taking care of them. And these kids were 350, 400 pounds. And like, what am I going to do for them? Tell them to eat less, exercise more? Actually, George Bray, the father of obesity medicine in America, back in 1975, had locked 8 of these kids up on a metabolic ward at Harbor UCLA Medical Center, threw away the key and gave them 500 calories a day for a month. And they gained weight.
Makes sense.
Weight.
Yeah.
They gained weight on 500 calories a day because these kids would rather store it than burn it.
Yeah.
Now, we knew that these kids released very, very high levels of the hormone insulin. Okay, and insulin, of course, is the diabetes hormone. You know it well. You probably, administer probably a good 1,000 prescriptions a day for insulin in your, pharmacy practice.
Yeah.
Okay. Well, that's not really what insulin is. Insulin is the energy storage hormone.
Yeah.
Whatever you're not burning, you have to store, and insulin is the way you store it. And so high insulin to me meant more storage. So I said, well, these kids, their leptin is telling their lack of ability to see their leptin is telling their brain they're starving. So their vagus nerve is putting their beta cells into overdrive. And so they're releasing insulin like crazy in an attempt to try to store more energy to try to get their leptin levels up even higher, but the brain still can't see it because it's dead.
Yeah.
So what am I going to do? How am I going to help these kids? So I said, what if I blocked insulin? What if I got the beta cell to reduce the amount of insulin released? And there's a drug that can do that. It's called octreotide, which I'm sure you also administer.
Yep.
And so we did a clinical trial, open label, 8 patients, IRB approved, all the bells and whistles. And lo and behold, these kids started losing weight. But even more remarkable than that was they started exercising spontaneously. Yeah. One kid became a competitive swimmer. 2 kids started lifting weights at home. One kid became the manager of his high school basketball team, running around collecting all the basketballs. These were kids who sat on the couch, ate Doritos, and slept. Yep. This was absolutely mind-boggling that I could change their physical activity. I could change their quality of life by getting their insulin down. Yeah. So we did a double-blind placebo-controlled trial. And guess what? Same thing. And we showed that the degree of insulin suppression correlated inversely with the degree of physical activity. So the more we suppressed the insulin, the more physically active they were. Yeah. So what this showed us in a causational paradigm, proof positive paradigm, was that the gluttony and sloth that we associate with obesity are not behaviors. They are biochemistry. Yeah, absolutely. Biochemistry drives the behavior. Right? And I published a paper in 2006 saying that. So that started me on my journey. You asked, how did I become an iconoclast? How did I start, getting, going off the rails, as it were, that was sort of the linchpin that's told me that all the things that I had learned back in college that they told me to forget were actually really what's going on. And really what I needed to do was forget what I learned in medical school. And since that time, I have sort of been a thorn in the side of the medical establishment, and for good reason.
And long may you remain so. You and Asim and Tim Noakes and so on and so forth.
It takes a lot for a doctor to get woke. Yeah. But that's what we are. We're a bunch of woke doctors, that sort of now get the paradigm. It took a while. It's hard when you're not taught it. You sort of have to find it yourself.
All of us have a journey like that. I mean, everyone I've had on the podcast has a journey that ended up not where they started. I mean, the same for me. I was conventionally trained. I thought statins were magic bullets with no side effects, eat a little, all of that stuff.
Right.
Until I discovered for myself, it just doesn't work.
Right. Exactly. It
On
doesn't
an
work.
N=1 basis for myself.
Well,
And you
see,
look
that's
around at your patients and you think, well, I started out as a fresh-faced young professional. I was going to do all this good. And all I'm doing is pumping more medication into people. They don't feel better. I don't feel better. And no one's getting better, but the drug bill's going up.
right. Well, see, that's the thing, Graham, is you just said it. Okay. N's of one are not science.
Yep.
Okay. And everyone is their own N of one. So there may be some patients that statins do work for. Indeed. Yep. If you have familial hypercholesterolemia, God knows you do need a statin.
Sure.
Okay. And a low-fat diet and a lot of prayer too. Yeah. All right. But that's your N of one. Okay. And familial hypercholesterolemia is only 1 in 500.
Yeah.
So for that patient, they need a statin. So I'm not telling you get rid of statins. I'm telling you, use the statin for the right patient.
100%.
Okay. You fix the pathophysiology, and then the medicine works. So I'm not anti-medicine.
Yeah.
But what I've learned is that the diseases that we treat, these chronic metabolic diseases that currently account for 75% of all healthcare expenditures in the US and the UK and many other developed countries around the world. Okay. These 8 diseases, and here they are. Ready? Type 2 diabetes, hypertension, dyslipidemia, cardiovascular disease, cancer, dementia, fatty liver disease, polycystic ovarian disease.
Yeah.
These 8 diseases, which now account for 3/4 of all the healthcare costs, they are not druggable.
Yeah.
Okay. You are a pharmacist dispensing medications for all 8 of those diseases, yet those diseases are not druggable.
Yeah.
What you're drugging are the symptoms of the disease.
Yeah.
You are not reversing the disease. Not one of those diseases has a reversal with medication.
Yep.
Okay. So yes, high LDL. Statins treat high LDL. I don't argue that, but the high LDL is not the disease. The high LDL is the symptom of the disease. Okay. High blood glucose. Yes, oral hypoglycemics and insulin treat the high blood glucose. I don't argue that. Okay. Yeah. But the high blood glucose is not the disease. It's the symptom of the disease. Disease is still there. Okay. And it never goes away. Okay. In each case, we are treating the symptom, not the cause. And when you treat the symptom, nothing gets better. It's like giving an aspirin to a patient with a brain tumor because they have a headache. Might help the headache, ain't going to do a damn thing for the brain tumor. And this sort of epiphany, this sort of notion that, yes, the diseases that are, the ICD-11 codes are actually not the diseases, was the reason why I had to write the book.
Yeah. So
what are the diseases? And this is where the longevity piece comes in. Okay. So in the book, I describe the 8 subcellular pathologies that go on inside all cells in your body all the time. And they are part of normal living. You can't stop them. What you can do is you can either speed them up or slow them down. That's what you can do. Now, when these 8 subcellular pathways are working right, you'll be 110 playing tennis. You will have the ultimate in longevity. You will not just have longevity, but you will have health span.
Yeah.
In other words, you'll be, as was said, you'll die young as late as possible.
It's interesting because you made a conflation to get metabolical of diabolical and metabolic.
That's right.
And my program is also a conflation of longevity and pro. And I spent so long thinking up the name because the whole point is, to live longer in good health, or as you say, die young at a very old age, or however you want to put it.
Right.
I completely agree.
Dying young as late as possible.
Yeah.
Thank you for watching. And before you leave, if you haven't subscribed, please do so you don't miss future episodes with Robert and with more of our fantastic guests. Just click here.